Hello, everyone, and welcome to today's seminar. My name is JJ Rotman, a representative of Ortholine, a medical technology company. We've partnered with Eric Tannenbaum, an orthopedic surgeon at Southern Indiana Orthopedics, to hold a seminar and discuss knee pain and available treatment options. This is a Zoom webinar, so everyone is automatically muted. If you have a question during the presentation, please type them into the question box on your Zoom control panel. You can access the question box by clicking on the icon that looks like two speech bubbles with a Q&A text next to it. It's located at either the bottom or right-hand side of your screen. After clicking on the icon, a window will pop up where you can enter and submit your questions. I'll be notified when this happens, and we'll have time at the end of the presentation to answer everything that comes through. So without any further delay, I'll transfer the controls over to Dr. Tannenbaum, and we can begin as soon as you're ready.
All right, thanks a lot. So this is my first time doing Zoom, so bear with me on this. This presentation is going to be talking about Neoline, as he mentioned, as well as kind of just my thoughts on it and why I like to use it when doing total knee replacement. So my practice is called Southern Indiana Orthopedics. It was established in 1976. There's 6 orthopedic surgeons and a podiatrist. It's comprehensive musculoskeletal care. We have physical therapy, MRI, as well as a surgery center that we can utilize for patients that are good candidates for outpatient total joints where you kind of go home the same day. And then our locations are in Columbus, Seymour, Greensburg, and North Vernon. The 2 locations that I go to are Columbus and Greensburg. So a little bit about my background. I did undergrad, medical school, and residency all at the University of Michigan. I then did an extra year in fellowship training with subspecialty in Los Angeles at Southern California Orthopedic Institute, which is an affiliate of UCLA. So during that year, I spent time working on arthroscopic surgery as well as working with joint specialists and gaining specialty training on arthroscopy and hip replacement and knee replacement surgery, as well as shoulder replacement surgery. Topics for today are what is arthritis, symptoms of arthritis, treatment options, non-surgical and surgical, as well as Neoline surgery, and kind of discussing what Neoline surgery entails. So what is osteoarthritis? If this sounds like you, there's a good chance you have it. So you no longer participate in activities that you enjoy because of joint pain. You seek out a parking spot as close to an entrance as possible because of pain or discomfort, or you find yourself riding the elevator instead of taking the stairs. So you're not alone if you're one of these. If you have any of these symptoms, likely it's osteoarthritis, which is the leading cause of knee pain. And what it is really just a breakdown of the cartilage of joints. So when this cushioning of the joint wears out, the bones begin to rub together, causing pain, stiffness, and damage. And the number of people that have arthritis is actually staggering. There's 19 million people that are living with arthritis, which is 1 in 5 Americans over the age of 40. And osteoarthritis is the most common form of arthritis, and a leading cause of disability worldwide. So arthritis is a progressive disease. Early stages, or what we call mild disease, patients might start developing kind of sports-related injuries, like you twist your knee and you start feeling a little bit of a pain after twisting it. Minor defects or loss of cartilage start to develop in the knee. So if you look at this picture, there's just a small little divot in that white, smooth cartilage that may start giving you some fits, but it's not horrible. Mid-stage or moderate disease, you start to develop some increased pain, reduced mobility, so you start getting a little stiffness, changes to lifestyle and activity. You start noticing that you might have to, adjust the activity level that you're having and decrease your running and start doing low impact exercises. And typically this involves partial knee disease. So it's usually a single or bicompartmental disease instead of all 3 of the compartments within the knee. And then the late stage is you start having a leading cause of disability, severe pain. Walking and stair climbing become very challenging. And you end up getting total knee disease, meaning that it's in all 3 compartments. So you can see on this picture, it's in the lateral compartment out here, the medial compartment here, and what we call the patellofemoral compartment, which is under the kneecap. So the symptoms of arthritis are pretty consistent. It's usually joint stiffness, swelling. Sometimes if it's bad enough, you can start developing leg deformity. We call it varus or valgus, but really what it is bow-legged or knock-kneed, where it starts kind of bowing out or bending in. You start developing something called crepitus, which is a grating sound or sensation with bending or extending your knee, as well as pain, which is preventing normal or desired activities. So the discussion you'll typically have during your first time of being assessed for joint pain, we obviously take x-rays to assess how much joint space is left. It's important to know on a personal basis how painful is your knee. Some patients come in and their x-rays look really horrific and they're not in that much pain. So I always say you have to treat the whole patient, not just the x-ray. Other patients come in and it's, their x-rays don't look too bad. They still have a little bit of joint space left, but they're in a significant amount of pain. It's also important to see which of the following symptoms patients are experiencing. This is kind of just a list of common symptoms that you experience. And then also asking the right questions, like if you could move without knee pain, what would you like to do? A lot of patients are just trying to get back to walking, but some people want to get back to more active activities. And then what concerns do you have about your treatment options? So these are all things that we'll kind of discuss during first visits and talking about knee arthritis. So what are your treatment options? The initial treatment for knee arthritis is obviously not surgery. We don't talk about the first time I see you in clinic talking about a total knee replacement unless you've already tried everything else. But initial conservative treatment includes weight loss. For every pound of weight that you lose, your knee feels 3 to 5 pounds of offloading per step. Rehabilitation, so therapy, warm baths, knee bracing and walking aids like a cane or a walker, as well as over-the-counter medications like aspirin or Tylenol. And sometimes we'll even give you a prescription for Mobic or Celebrex or naproxen, different anti-inflammatory medications. There's also different types of injections you can do. Steroid injections are very common. And the goal of a steroid injection is to reduce the inflammation and associated pain within the knee. The pain relief from these typically lasts 6 to 12 weeks, but sometimes it can last 4 months. And I've had other patients where it's lasted a year or longer. If you failed steroid injections, one other type of injection that we offer is hyaluronic acid. So what this is called viscosupplementation. It's a long word, but really all it means is a viscous fluid, which is kind of a slippery, slick fluid that we inject to allow for a more smooth gliding knee joint. So it acts differently than the steroid injection because this is more of a lubricant, whereas the steroid injection is more of a potent anti-inflammatory. And this pain relief often can last up to 6 months, but it's varying results. So there's two main different types of knee replacements when you hear about people talk about them. There's a partial knee replacement, which is where if you only have arthritis in one of the 3 compartments of the knee, then you can replace just that compartment. So oftentimes it's this medial compartment here is the only one that's arthritic, and you can just replace this portion of the knee. This maintains the knee anatomy that is functioning properly. It's less invasive than a total knee replacement, potentially faster recovery than a total knee replacement, and it may improve some outcomes. Once you've kind of developed arthritis throughout the lateral compartment of the outside of your knee, the medial compartment and the inside of your knee, or your patellofemoral compartment, then we're typically starting to talk more about a total knee replacement in terms of surgical intervention. Because obviously if you only replace one compartment, the other 2 arthritic compartments can still be pretty bad pain generators. So at that point, you now are not a candidate for a partial knee replacement. I typically err on considering just doing total knee replacements rather than partials, just because I feel like it's the gold standard of care. But younger patients, if they only have unicompartmental disease, then it definitely is a consideration to think about just doing a partial. So what a total knee replacement does is it resurfaces the tibia, the femur, and the patella. So you make a cut on the tibia here. So you take off the arthritic bone that's here, and you'll put this tibial base plate in with this little plastic poly. you make some cuts on the femur, and then you fit this, you size the appropriate sized femoral implant, which is this metal implant. And then on the undersurface of the patella or the kneecap, you resurface that and put a little plastic piece that can slide in and out of the new knee. So why does alignment matter? So alignment is extremely important in total knee replacements. It's important because of longevity and in ambulating, and it has a very important impact on the overall outcome following the surgery. What you want from alignment is it should create a straight line from the hip, the center of gravity through the hip, through the knee, and directly through the center joints of the ankle. So what that does is lines up the mechanical axis while you're walking, so that each time you step, the mechanical axis is all well aligned and you're not having what we were talking about before, varus or valgus deformities, which then could cause more issues in the future. So the proper alignment may improve recovery times, reduce pain, reduce the need for surgical revision surgery, and reduce stress on the joint line and implants. So this device here is something that I use in my total knees. It's kind of what we're here to talk about. It's called knee align surgery for total and partial knee replacements. And it's a little computer assisted navigation for your total knees, so that you're making sure that all your cuts that we were talking about before are precise, instead of just kind of eyeballing it or using other jigs. So the reason I use knee align is, again, because it provides real-time feedback on where I'm putting your knee implant and ensures an accurate and precise result. So rather than, there's all different ways to do total knees. By no means would I say that one way is wrong, but I like using the technology that we now have today on our side to make sure, as a double check, that what we are doing is as precise and as accurate as possible. Because if it's my knee, I want something like that to help make sure that everything goes perfectly. Just like we rely on our phone in our pocket to get us where we're going, knee align, I feel like, is similar in that it provides that feedback on where you're putting the knee implant and ensures an accurate and precise result, rather than kind of how we used to look at maps and you might get lost or turned over. This is more real-time feedback. So the way that it works is it virtually reconstructs your specific tibial anatomy. So the tibia, or the shin bone, is the bone where it's really critical at what angle do you cut this to restore that mechanical axis, which is the line that you're seeing drawn here on the right. And what the end goal is again, a precisely aligned implant, which should then last you a long time. It works similarly in the knee. Again, it virtually reconstructs the mechanics of the femur. And so you can see, again, the goal is to have the red line that you see drawn from the center of the hip through the center of the knee. And this allows you to preserve the bone and to make the cuts more precisely, rather than some of the other ways that you can do these replacements. So some of the common questions that I get, if anybody has any, feel free to chime in, or if we're going to post this later, and anybody that has any other questions, feel free to write a comment below, and I'll try to get back to you. But some of the common questions that I have are, when should I consider a knee replacement? So I always tell people, if it's affecting your daily life, and after failing conservative treatments, that's usually when it's time to start thinking about having a knee replacement. It's an elective surgery. It's not going to kill you if you don't have it. And there was a time when we never had this technology and nobody was doing knee replacements. So it's a very personal decision. Another question I get is, when can I walk after knee replacements? Typically, patients are up walking the next day. In most cases, they're walking with a walker or a cane, just to make sure that you're safe. How long does it take to recover after replacement? Typically, it's about 3 months. Usually you're up and walking sooner than that, and some people are off canes, even earlier than that. But in terms of when you're going to kind of be really back at it, and you're not going to really notice much of a difference anymore, and you're just going to start having real good pain relief, I would say typically it's about 3 months or so. And the last question that I think is a pretty common question is, how long do these replacements last? So I always tell people, the research is still ongoing. But in terms of outcomes that we have, most studies show that these knees are lasting 20 or more years. So again, one of the factors in how long these last is how precisely it's put in and what angle is the cut made. So that's why I think it's critical, and I like to utilize everything I can to help give the patient the best outcome possible. So if you guys need to get a hold of me, or if anybody out there feels like they want to have a consultation, or if they're having knee pain, there's three ways that you can get a hold of me or come in and see me. One way, that probably the easiest, is just to give our office a call and ask to schedule an appointment with me for an evaluation of your knee. The second way is our website actually does have online appointments. So you can go on, find me as the doctor, and request an appointment. And then lastly, if you look me up through Facebook, I do have a book now option where you can just book through Facebook, and then I'll have our office reach out to you and just confirm the appointment. So that's pretty much it. If anybody has any questions, again, I think we're going to try to post this on Facebook later for other people that missed it live, and I can answer any questions if you guys have any questions later through comments. And I just want to thank you all for listening, and happy to see you, or if you have any other issues or concerns, give our office a call, and I'm happy to see you.
Yeah, it doesn't look like we have any questions today. So just to reiterate what Dr. Tannenbaum said, the recording will be made available to everyone, and we'll make sure to post that on Facebook and through other mediums. And everyone who registered today and attended the meeting, a follow-up email with all the contact information that he provided will be sent to you, so you don't have to look it up. And thank you for your time. And Dr. Tannenbaum, thank you very much for your time as well.
Thanks a lot.